Thank you, Veronica. Our last plenary group of speakers this morning come to us from Kentucky. And those of you who have worked around birth outcomes, particularly infant mortality, know that sometimes we commiserate with our fellow states. Sometimes we even say thank goodness for those states because they're in the rankings lower than we are. But I think one of the things that you've seen this morning from all our speakers is that we are making progress, not only as a state, but as a region. And we don't have to look very far to some other states to see some great examples of what's going on. And so that's why we asked our colleagues from Kentucky to come this morning to talk to us about what they're doing with the Healthy Babies Are Worth the Wait campaign. So we're going to hear from two colleagues. The first is Ms. LeAnn Todd Langston. She is the manager for the Center for Women's Health of Trover Health System. And in that role, she oversees direct daily operations of multi-provider outpatient care delivery in the specialty of obstetrics and women's health. We're also going to hear from Katrina Thompson, who is the State Director of Program Services and Public Affairs for the March of Dimes Greater Kentucky Chapter in Lexington. She's worked with the 4-H Youth Development, as well as the Kentucky Perinatal Association, the Kentucky Birth Surveillance Registry Committee, and the governor-appointed Perinatal Task Force for Kentucky. So please welcome our colleagues from Kentucky to tell us about Healthy Babies Are Worth the Wait.
Well, good morning. Thank you so much for having us. I'd like to start off by saying I am not LeAnn Todd. I am Katrina, so we just switched it up on Michael there and decided to do it a different way. Again, thank you so much for having us, and we're really excited. You know, it wasn't that long ago that we were exactly in the same place everybody else was, thinking that we really need to do something about our late preterm birth rates, about our infant mortality. So here's what we did. We came up, it was the brainchild of Dr. Carla Damus, if anybody knows her, with the March of Dimes. We all sat one evening while we were at the Kentucky Perinatal Association about 11 o'clock in our pajamas, and we said, what can we do? How can we write this grant? What can we do to address this in our state? So we had a 3-year initiative. It was really a real-world project. We decided to do anything and everything that we could using evidence-based practices around public health intervention to try and help a woman have a full-term pregnancy and have that the best way she could. So we started out with a goal of reducing by 15% single-term preterm births in Kentucky. We chose 3 hospitals. We also looked at what could be preventable among those hospitals. We started out with consumer awareness and education because that's the piece that's sometimes missing most. Professional education, public health interventions, clinical interventions, and quality improvement strategies. As you can see here, we do like those surrounding states and other states. So we thought, well, what's everybody else doing? How do they look in comparison with us? So we did look at the U.S., which is in red, at Kentucky, that's in blue, go UK. West Virginia is also in blue, Virginia in green, and then you all Tennessee. So we found out that none of us were really that far apart. Virginia was probably the closest to the national level, but for the most part, the 3 of us were running right there. So we thought this is definitely a problem that we need to address. We looked at Region 4, and we also looked at this by race, by white, black, Native American, Asian, and then the total. And as you can see, in Region 4, Kentucky still, for the most part, other than the Native American, Kentucky still had the higher average there. We started out, we figured we needed some baseline information to start, and so we did that. We looked at planning and training. We spent about 6 months really, or a little bit better, in planning and training and trying to get everything together, getting our sites on board. We had to have enough births so that it was statistically significant. And we had a preterm birth rate of over 13%. And our birth rate had increased 20%, and then 10% for the singletons in the past decade even. We really needed strong leadership from our state health department, which we have, Dr. Ruth-Ann Shepherd, who is wonderful, and that was really the beginning of our love affair and our what has become our partnership for life, it seems. So that's really certainly something that you want to do, and I can tell by your commissioner's wonderful words of support that you have that, and that's a very important piece. We looked at the criteria for this. We wanted to have the sites or the hospitals that had high or increasing rates of singleton preterm births. We wanted to look at the high prevalence of modifiable risk factors, what of those things could be changed, and then who delivered enough babies so that we could count. This is kind of what the sites looked like in Kentucky. We really covered the east, the west, and the central. We also had sites that were just small rural hospitals. We also had a university site. So we wanted to kind of get all different types. Some of them, like I said, had private practice physicians who delivered at the local hospital. Some had hospital clinic practice, docs, midwives, and then our university hospital that was more urban. We now refer to these lovingly as the 5 Ps. The first thing we wanted to do was engage partnerships and have that collaboration. And I can tell you, our collaboration in Kentucky has increased wonderfully. I mean, folks really know each other now where they didn't before. Provider initiatives, patient support. Not only did we want to educate the providers about a full 40-week pregnancy, but also the patients, because it was twofold. You know, if the doctor needed to schedule the birth, then we wanted patients saying, now why are you scheduling my birth? I've not gone into natural labor yet. And then also the public, churches, grandparents, people do get a lot of information from their friends, from their families, a lot of times from their mothers, grandmothers, folks they go to church with. So we felt it was important to also educate the public on this, and then to measure our progress, of course. We are very grateful to our national partners, which were Johnson & Johnson, and also the National March of Dimes that allowed us to do that. Within the state, we of course had March of Dimes, our state Department of Health. We engaged our local health departments, our local media. We have a very strong Kentucky Folic Acid Partnership that started back in 2000 that is still a working group that has become now a perinatal work group. Our Perinatal Association, and also our Public Health Association. We really wanted to get folks on board from the very beginning. So we included anybody and everybody that we thought had any kind of influence in this. Midwives, nurses, dentists, pharmacists, administrators, communications folks, those in quality improvement. Basically, anybody who would listen and become involved with us, that's who we recruited. We did the provider initiative. We did lots of traveling together. We did grand rounds. We come up with what is we refer to now as the brain card, and it is information about the brain development in those last few weeks. We wanted to remind them, this is not a new thing, this has been in the ACOG guidelines for some time now. We're not telling you anything new or different. We're looking at treatment of infections, looking at resource centers, patient safety, oral health, psychosocial screening, smoking cessation, breastfeeding, anything that we could do around this, basically, we did. We actually developed some brochures that had actual pictures of Kentucky women on there. And we educated women about a full-term birth really needs to be about 40 weeks until you naturally, labor begins on its own. We did a lot of talking about the brain development, early referrals to public health programs to get them into WIC early, home visiting, smoking cessation. We used a Kentucky Quit line to help with that. We had health literacy brochures and stuff that were developed on a lower reading level so that everyone could take advantage of those. We really started talking to women about pre and interconception. We used things like Text for Baby and lots of other materials. Basically anything that they would take, we gave to them. We used totes, t-shirts, toothbrushes, pens, little pens. Oh, actually the one at the bottom here with the baby on it, this was a little magnetic thing that you could just stick on your refrigerator just to remind you a little bit, and they could put the picture of their own baby in there. It was a little picture frame. These are the beautiful brochures that Johnson & Johnson came down and photographed for Kentucky, and they are beautiful. They talk about every week counts. We have them both in English and Spanish. And then the March of Dimes, we had the patient brochures also that talked about preterm labor, the signs of preterm labor, what to look for, that it's better to be safe than sorry. We did newsletters for our staff, for our sites, anybody again that would listen. We did interesting articles. We sent out to them the most cutting edge information that we could get. We set up a resource center at each of our intervention hospitals so that they would have them on site there to read and to look at. We also, from the March of Dimes, they actually stole it from Healthy Babies Are Worth Wait, but that's okay because it was so fabulous. I'm sure they all wanted it they wanted the world to have it. So then they created Why the Last Weeks of Pregnancy Count, which also gave the same information because we were so overwhelmed with other states, other sites in Kentucky wanting that information that we had to make sure and give it out. Again, you know, our governor came and helped us kick off this program. We devised a Kentucky toolkit that had information about how to do a media campaign, how to educate folks about this in your own community, small community. We had Ask Me about Healthy Babies Are Worth a Wait buttons. We had media stories. We used Facebook, Twitter. We did lots of professional meetings. Again, anybody who would listen, we told them. One of our progress measures that we looked at here, as you can see, in 2007 in March was our official launch of this. So one of the great things that we began to look at when we looked at our year averages in 2007, 2008, 2009, and maybe we're a little presumptuous to think this, but we weren't doing anything else any different in Kentucky during that time except Healthy Babies Are Worth a Wait. And as you can see to your far right there, in the colored area, shaded area, each year it went down from 13 to 12 to 11 to 9. So we really feel like we are making a difference. One of the other things we had was a grade card for physicians. Many of the hospitals utilize this, and you know, some of our folks only had, this is an actual report card, so it's not hard for the docs to figure out who A, B, C, and D is, and they would sit around the table, and if this wasn't good, they would lovingly remark, what's going on with you, D? You're dragging us down. So it was really good for them to have that peer-to-peer review there, and as you can see, it paid off very well with no infants being admitted to the NICU for this particular report card. This is one of the better report cards, I would like to say. This is really the main thing that we are really still reaping the great benefits and growing in Kentucky is our collaboration. We went from hospitals not even knowing what the health departments did in their area to now there is a collaborative union between them. They room together when they travel together. They know people's names. They know who to call at the health department. The health department knows who to call at the hospital. And it really was a great bonding experience for our communities. And we get together in person twice a year. These folks are still excited. What we are currently working on, what they decided to currently work on, is that we now have 8 sites in Kentucky, 8 Healthy Baby sites, and each hospital has decided that what they want to work on as a group, as a goal, is having a hard stop policy in place at every single one of those, and for it to continue to grow. So it has been phenomenal for our state and for our team and for working together. And what the wonderful thing is, when we began to talk about this with ASTO and all of these things and the infant mortality, it was just like a beautiful symphony that began to play together, because that's what our state chose. And we thought, well, we can certainly affect our infant mortality through looking at our late preterm birth rates and getting those down. So it just all came together very beautifully, and it was so exciting to see that, and it's such an exciting time for us. And our folks are still so interested that once a month we have a call, and every single one of our sites are on there at every call. It only lasts for 30 minutes, but they're still excited and they want to keep in touch and they want to know about each other. And I'm going to let LeAnn Todd, my co-worker, come and tell you about everything. LeAnn is actually, she was one of the coordinators at her site at Trover, and was one of our original sites. So we have been in this from the very beginning, and now our baby, Healthy Babies Are Worth the Wait, we feel like it's our baby because we gave birth to it. It has now grown up and gone to New Jersey and to Texas.
Thank you. It's an honor to be with you all today. And it's going to be interesting. I want you to see from a clinical intervention side about how Healthy Babies changed our practice. And I really feel like it helped our mothers, our families, and benefited our community. So I want to just talk a little bit about some of the interventions over the 3-year time that we implemented at Trover Health System in Madisonville. We were the intervention hospital for the western part of the state. So one of the things that we implemented was to eliminate elective deliveries and cesareans prior to 39 weeks. And though that sounds very simple, anybody who works with obstetricians, you know that was more than what it was a lot of work. And it took the support of the March of Dimes and Healthy Babies to bring in those expert presenters to talk about the evidence-based practice and to show cutting-edge research about how important it was to follow guidelines and to change their practice. Group prenatal care, centering pregnancy, is a model that we implemented in 2006. Can I have any, please raise your hand if you've heard of centering pregnancy or that model. Okay, good, that's wonderful. Well, centering pregnancy is a unique model that I can tell you far outdoes traditional prenatal care, so we were very fortunate to be able to offer that. We started with our nurse midwives implementing the model, and I'm proud to say that currently today, we also have our OBGYNs who also facilitate groups as well. One of the things, too, that we started along with the Healthy Baby support was that we started using the 17P progesterone. We implemented that to see if we could help, there again, prevent the preventable births. Another area that we really focused on, which is so broad, is preconceptional and interconceptional care, and that is so much about addressing things that we just really had never thought about before. When we thought about, behavioral health, we thought about stress, we thought about mom's environment, we took a needs assessment of our organization and we started looking at what resources do we have in the community? What barriers do we have to these resources? So because of the initiative, it really helped our organization look to see where we had gaps and where we could fill those gaps. Another thing that we were very proud of was the improved access to our health department. We liked the people at our health department. We didn't have anything in the world against them. We just weren't working with them in the way that we could. And that was one thing that Healthy Babies, that public health environment was so important. And one of the things that we did, we actually developed a referral form. And on that referral form, it had all of the wonderful resources and services that our health department has, such as the WIC, the HANDS program, the smoking cessation. And on that first initial visit, what we would do is we would talk to that mother about the health department and the public health programs, and we would get their interest, and then they would sign that they wanted to be contacted by the health department. So that nurse would take that fax form, fax it to our health department, and then they would make the contact. So we were also offering our mothers such wonderful services, but we were helping our health department get those women connected and get them into those services. One of the things, too, that we started really looking at was transportation. Is that an issue in our community? Well, a lot of times we assume because a woman isn't there that she just didn't show up. Well, with gas prices being the expense they are, we understand now why transportation is even a bigger issue, how we have to coordinate that, how we have to work with our community resources to see that our mothers can get into their care. Health insurance. Kentucky Medicaid has presumptive eligibility. We implemented that in our office of where we can sign women up. We screen them and we sign them up there in our office, and we try to take some of the financial burden off of them, worrying about, I don't have insurance. What am I going to do? I can't work, or I don't work, and what, I need to get to the Medicaid office, but if we can handle it there on site, we saw that we were really opening up a lot of access, not only for our mothers and our families, but also really for our organization. The sooner we were able to get them signed up for presumptive eligibility, it was a win for us also. In our area back in 2007, there was one dentist who would see Kentucky Medicaid patients. Now, they would see Medicaid patients one day a month, and it was on a walk-in basis. So you can only imagine that we had a horrible access to care issue because we had dentists who were afraid of pregnant women. And there was a lot of education that we did around the Healthy Babies, bringing in those experts. Katrina was wonderful about getting, dentists on board who was coming into our community, speaking to the dentist, telling them it's okay to treat moms. Matter of fact, we really want you to take care of any infections they have. If they have any abscess teeth, please take care of them. We want to get that taken care of. I'm very proud today to tell you that oral health is not a problem in our community, and it's because of the Healthy Babies Initiative. It's the education, and it's also the working relationships with the dentist, because it's amazing. I think sometimes as maternal child people, we think that no one else really worries about these mothers and babies like we do, but it was pretty amazing when dentists would come in and they would sit in on a lunch and they would hear about all the potential impact of oral health problems or inflammation and how it could potentially cause that woman to go into early labor. And they were concerned about that because they said, that's our mothers, that's our community, we're stakeholders too, even though we're just dentists. So they were part of the perinatal team. Once again, stress management was huge because we really started looking at prenatal stress. Of course, now we look at a lot of preconceptional stress because over 3 years we've been able to work, kind of looking at it before pregnancy. But we were able to look at the access we had to behavioral health and what our community had to offer. And I will tell you, it was extremely, extremely limited. I've been an OBGYN nurse for over 17 years, and I was so very frustrated with our community mental health center because I wanted them to focus on women. I wanted them to reach out to the women, and I wanted them to help women. We were finding difficulties referring people when we were in crisis. So we were having difficulty when we were trying to be reactive, and really what our goal was to be proactive. We really wanted to screen our mothers to keep them from going into crisis. And with the Healthy Babies initiative, Dr. Ruth Ann Shepard was so fundamental in being our lead person to, she made the mistake of saying, if you ever need anything, please let me know. And she was very open to, please call me, please email me. And I have to tell you, there wasn't one time that I would call her and say, Dr. Shepard, I've got this going on and I really need some help, that she didn't get back with me and say, here, LeAnn, here's a couple of options. Let me know how it's going. I want to follow up on this and I want to see what we can do. So as a nurse manager, that was key, and that was such a valuable tool for me to have at my disposal, because it was kind of in the back of my mind. I was thinking, well, if this doesn't work out, I'm going to call Dr. Shepard. She'll take care of it. One of the things we started in 2008 was universal prenatal drug screenings on the initial visit. And prior to that, the reason we did drug screening was if we had a mother who was non-compliant with care, if she self-admitted, which you can imagine was not very often, or if we had a stillborn. So during the Healthy Babies Initiative time, we started looking at that, and we started thinking about, why are we waiting until there's a bad outcome? Why are we waiting until this baby's ready to be born to address this? If we can get mom in and get her help as soon as we find this out, we have a better chance of improving her outcomes. I can tell you that in Western Kentucky, 1 out of 3 women test positive for at least one illicit substance, okay? That's not including tobacco or alcohol, okay? So what we started doing was we started screening, we started educating, we started referring. And in 2010, now all of our mothers on admission to labor and delivery receive another drug screen. So we have been very pleased with that, because a lot of that is education. A lot of it is just screening. I was so amazed at the number of women who would just say, when we would sit down and we would talk to them about, okay, here's your CBC, here's this, here's that. Oh, and by the way, your urine drug screen is positive for marijuana. And they have this look of surprise, and they say, oh, well, I'm really sorry. I've been really nauseated. And you say, well, it's illegal and you're not on chemo, so you can't do that. And it was amazing that the next time that we would randomly screen them, they would be negative. And I think a lot of it was because we decided we're going to address this. We're not going to keep our head in the sand, because we know it's the right thing to do, and we've got to start addressing it before there's a bad outcome. So breastfeeding support groups, that was something we initiated during the Healthy Babies project. We, like most places, had a lot of opportunity to improve our breastfeeding rates. And that was one of the things that we felt like we could offer the mom support groups. Centering pregnancy gives a really strong fundamental base for breastfeeding, but we thought after they deliver, they're going to need more. They're going to need more support to be successful at it. And then we looked at case management. We need a true perinatal team. This is not something that belongs to this department or that department. It's got to be a team approach, and that was something that the March of Dimes was really, really encouraging for us to figure out a way that we can better handle the care. So over a course of a 5-year span at Trover, what we were able to do, and this is to the end of 2010, we were able to decrease our primary C-sections by 9%. We were able to reduce our inductions of 34 to 36 weeks by 22%, and we decreased our low birth weights by 33%, and then our preterm births decreased by 18%. So when I asked you about centering pregnancy, the reason why I think that we have been able to change the care that we give is because centering pregnancy is a wonderful vehicle for social change. And that's really what we were looking to do, was to improve outcomes and affect our mothers. So there's a little information about that. We also implemented the California Maternal Quality Care Toolkit in November of 2010. All right. And I just wanted to briefly show you that we had, because of the Healthy Babies and some of the work that we have been doing, and we're just getting started. That's the key, is we're just getting started. And it was because of that collaboration with other hospitals in the state, and also with our public health and with Dr. LeAnn Shepard, who is such a wonderful director, that I really feel like in Kentucky, maternal child outcomes are only going to get better. So, all right. And that shows you a decrease in our late preterm deliveries. Very quickly, Some keys to success. I've been given the stop sign, so I've got to make this really quick. Resilient. You've got to be tough. If you change care, you really have to be tough and you don't give up. Innovation. We all really have to be creative. We have to think differently. And whether we're nurses, we're WIC workers, we're public health workers, we're doctors or midwives, we have to think differently than we ever have before. And we have to collaborate. We have to get with our people. Okay. Leadership is very fundamental. We have to have that, along with engagement. We have to step out of our shells and we have to engage people. We have to engage our publics. We have to engage our patients and have stronger communities. All right. Thank you all very much.
Thank you, Katrina and LeAnn. That was wonderful. So exciting to hear about great work that is happening not very far away. And they will be here today so you can pick their brain about what made this work well and think about how you might do that in your community.